today. So headaches are extremely common, as you can see. Every other patient has some kind of pain or discomfort associated with the head. And I thought we would discuss it for a few minutes, and then I'll give you a reference. It's a nice review article. It's called Diagnosis and Management of Headache by Dr. Robbins. And what he did, he's from Cornell, neurology. And what he did was he looked at all the articles published the last few years on headache. And he put together a nice kind of a concise summary about headache and why it's important, and also different types of headache, and also treatment. And what are the characteristics of major primary headache disorders? Maybe we can do it together as a group. Why don't we start? Tell us a little bit about what kind of headaches do you know? Okay, so there is a secondary type of headache, and we'll spend only a few minutes on that, but that's associated with bad things like brain tumors or infections or metabolic problems, etc. So we'll talk primarily about primary. Let's divide the primaries. Give me one type of primary headache. Migraine, exactly. Yes. Hi. Another patient.
I have a VA referral for concussion without loss of consciousness.
Okay, now that's a tough one. Concussion without loss of consciousness, maybe alteration of consciousness. Can we spend like 5 minutes? We're talking about headache.
Sure.
And it's being recorded by Dr. Stein.
Sure.
So this is just a quick kind of overview of headache. So one type of headache is migraine, right? Migraine. And what is the characteristic of migraine?
Like throbbing headache, unilateral, can last for
Okay, so it's unilateral, it's throbbing, usually young female.
can last for 4 to 72 hours.
Right, it can last for sometimes from many minutes to hours.
It can have auras, visual auras, nausea, dizziness, photophobia,
Exactly.
phonophobia.
Exactly. So that's migraine. What other types of headaches do we know?
Cluster.
Yeah, cluster headache. So cluster, how is cluster different from migraine?
It's usually like around the eye, and it's more present in males.
Yes, it's more in males, and it can be around the eye in the trigeminal distribution. And what else? So what about the presentation?
It has autonomic features.
It has autonomic. That's a very important aspect because it's thought to be related to the ganglion and the autonomic aspects. But also characteristically, it's very different from the usual migraine, although there is migraine cluster migraine. So there's an overview. Both of them can be similar, but typically cluster is a male, kind of middle-aged, frequently hard worker, outdoors, kind of an outdoors type, maybe working on the farm, and you could see that he has severe headaches. And so cluster can be very devastating. And it's a little different from the migraine. Okay, what are the types of headache? What did they? We've talked about it. Well, there's a muscle contraction type of headache, tension headache. We use different words associated with some kind of anxiety or more psychogenic type of symptoms, right? Okay. And then, of course, there are many other headaches that are secondary headaches that you mentioned, including from problems with the neck, chronic sinus problems. There are about 250 different kinds of head pain. And our job is to find which one it is, because we're kind of specialists in headache. As a neurologist, you have to be a specialist. Now, in terms of recognizing it, characterizing it, what about treatment? For example, migraine. Yeah.
And acute therapy, we have prophylactic therapy.
Okay.
Therapy, we can use triptan,
Right.
like
We
anti-manic drugs?
usually like to start with simple treatment, like Tylenol or even aspirin or something like powder or something easy and simple, Excedrin. You'll see that's the #1 treatment in the United States, and it's inexpensive and so forth. There's also a powder that's frequently used in DC by more of a older crowd. And then in terms of migraine that doesn't seem to get better from the simple treatments, then you go to other medicines. And we have at least 30 different types of medicines. It's unbelievable, so many pills for migraine, right? Now, I tend to like to use it as a preventative. If there's many headaches in a week, for example, you want to give the patient something to prevent the headache. And what do we use for prevention? Topamax, you said, yes. Beta blockers, yes. Calcium channel blockers, yeah. So there's a whole host of preventative, right? Nortriptyline, for example, is very good as a headache at night. I usually low dose, 10 milligrams, 15 milligrams. Elavil has been used for many years. What if okay, so you have the preventative. What if there is an acute attack after the preventative? What would you use?
Sumatriptan.
The which one?
Sumatriptan.
The sumatriptan, yes, sumatriptan is very popular now. What are the sumatriptans? Do you remember any of the? Imitrex is a very good example of sumatriptan. What are the potential hazards of sumatriptan or the Imitrexes? Which one?
Excessive vasoconstriction.
Vasoconstriction. So somebody with coronary artery disease, myocardial infarction, and so forth, you'd be a little more careful with it. What else would you use if they don't get well with the simple treatments?
Calcitonin gene-related peptides.
Okay, so now we're using the calcitonin gene receptor antibodies and so forth, which really a major change in our treatment. And we have a number of types that have come out, right? Oral medicines. And what else? Let's say that doesn't work either. What are the next other features, other treatments? Well, one of them that we use here is Botox. And Botox has been very effective. We have a number of almost, I would say, professional migraine patients. We call them migraineurs. And they've tried every medicine. They've been to many doctors. Finally, they come to the Botox. And there are a few pitfalls with Botox. You have to be careful because sometimes, let's say it's a unilateral headache and you're using Botox. If you give too much Botox at one time, you can paralyze the muscle. And so I had a patient that went to another neurologist who was giving them Botox, but a little bit too much Botox, and she developed ptosis. The whole eyelid came down. And imagine you're driving and you only have one eye, it's a problem. But I told the patient not to worry, because she went to sue the doctor and I said, no, don't do that. Let's give it a couple of weeks. It will get better. And within about 3 weeks, the ptosis went back to normal. I also had another patient who saw a neurologist where they were using Botox in the neck, and the patient developed a head drop like this. So she had to hold her head up. And I said the same thing, that will take a couple of weeks. And believe it or not, the muscles came back, etc. So there's some side effect. Be very careful when you're using Botox. Okay. When should you do an evaluation? Let's say it's a headache, normal neurologic exam. When should you do a CAT scan or EEG or other diagnostic studies?
When there are features of a dangerous headache.
When there's
Okay.
any change in the characteristics of it.
Okay, when there's been a sudden change, right? Or in somebody who's never had headaches before, somebody who's over 50 years old. Okay, somebody's over 50 years old, you're concerned.
Vomiting. Projectile.
nausea, vomiting, and so forth, increase intracranial pressure.
Morning.
Or when you're concerned about a change in their headache or head pain. And let's say the person is 65 and is having some pain on the side, throbbing, but pain on the side when you press it, it hurts. So you're worried about temporal arteritis. You're then worried about specific neurological headache associated diagnosis. Now, it's very controversial when you should do a CAT scan. From a sociologic point of view, you want to save money for the country, and don't do so many CAT scans. There's also radiation. There's some hazard cost and so forth. But then on the other side is every patient is different. They're worried. Sometimes doing a CAT scan, and the CAT scan is normal, it's very reassuring to the patient that you've done everything you could in terms of looking for something. Many patients come in to see us because their family member had an aneurysm or a family member had some kind of brain tumor or something else, and we will do it. It's controversial. There's no right answer, but so long as you could kind of explain it cogently and give a good reason for doing it, I think it should be done. I tend to be the one that tend to do it and have a baseline. Then we don't have to do it again and again and again. But some patients will say, Dr. Bernad, I had my CAT scan last year. I have headache now. Please do it again. I tend not to fight my patients, like argue with them and so forth and so forth. I don't think it's useful. I want my patients to feel comfortable. And if it is a CAT scan, I will probably do it. I have a philosophy of let's check it out rather than not. Sometimes we find incidental things like a meningioma or aneurysm tumor or something like that. So you have a chance to pick up something that's treatable, potentially treatable. And you say CAT scan, it's not CAT scan like $100 or something, $120. The radiation is minimal because they're very careful now, the radiologists, they minimize the radiation. So it is time consuming and it's uncomfortable. You have to go to the hospital or freestanding clinic, etc. But I would tend to do it. Okay. It seems like the four of you have learned a lot about headache. You feel comfortable in terms of evaluating patients. And what are the two things we always do when we examine a patient with a headache? What did I say?
Babinski and fundoscopy.
Babinski, and we look at the eyes, right? We look for papilledema because there's so much you can identify, but you must always look into the eyes, because if something happens and you miss something, and if you didn't do those two things, it's very embarrassing. It's hard to.
Hemorrhage, maybe also,
The who?
like hemorrhage.
Like a hemorrhage?
Yeah,
Yes.
I mean in the fundoscopy.
Usually, yes, but most of the time, papilledema, you don't want to miss papilledema, right? Okay, I'm not going to get into rare types of headaches. I think we've covered the most common things and kind of an overview. All right, Dr. Stein, that's it. Let's go and see the next patient. I'll make a copy for you